I hope this
Thank you very
Arabic
much.
statement is correct because I use Google Translator.
Thank you very much, Professor Kashani. It's really amazing and it's very interesting, and definitely AI is invading the world, and you have to know how to make use of it. Thank you very much.
Thank you.
It is my great honor and pleasure to present the last speaker, Professor Vesna Garovic. She is a professor of medicine, nephrology and hypertension, obstetric and gynecology at Mayo Clinic. She chairs the division of nephrology and hypertension and is vice chair of the research in clinical medicine. Director in Mayo Clinic Center for Clinical and Translation Science, and is the dean for the clinical and translation science across Mayo Clinics. And it is an NIH-funded researcher over 20 years with over than 200 publications. Our research focuses on hypertension, especially hypertension pregnancy disorders, and exploring diagnosis, treatment, and underlying mechanisms like senescence and epigenetics. She will talk about TMA and pregnancy.
I think there's been some miscommunication, but the organizers are aware, ICOM is aware. So Dr. Garovich, unfortunately, at the last weekend, she got notice that she has to essentially present to clinic leadership and was unable to travel. So they're supposed to have a recorded message and recorded presentation. Unfortunately, that has not actually connected to here. So this would really conclude the session.
I think we have 5 minutes possible for discussion, because these were very interesting 2 lectures. The first one by Professor Lauren Hernandez. Please come to the stage if any questions regarding your updates on pathology of TMA, and also the artificial. Please come to the stage also. So we have the chance of making some discussion for 5 minutes, maybe.
Can I start?
Oh, you can start.
Dr. Lauren. Thank you for your interesting lecture. I just want to ask you, any special pathological difference for TMA in a native kidney and in transplanted kidney? Any special difference? You can see this is a transplanted and this is a native.
Yes, that's a very relevant question, and I did not have time to go into that in detail because I wanted to convey a few messages to the audience, but the transplant TMA, it's another area that it's very unique, and of course, as pathologists, we not only have to consider things that we see in the native kidney, but also consider other possible complications related in the transplant, including antibody-mediated rejection and the specific drugs that patients get exposed in transplantation. So there is a current effort by the Banff Pathology Working Group to try to come up with some useful criteria to define thrombotic microangiopathy in the transplant. There is a pathology working group that has recently published a criteria. I was part of it regarding the minimum criteria that is necessary for the thrombotic microangiopathy diagnosis in the transplant, taking into consideration histopathology, clinical findings, and laboratory data. So to your question, it is a unique matter, of course, and we are integrating the knowledge that we have based on the histopathology, but like a transplant in the native kidney, it requires additional correlation. And one of the papers I presented today really emphasized the importance of complement in those patients, as we can see that eculizumab can be quite helpful to avoid graft loss. So.
If it is an acute antibody-mediated rejection associated, can you differentiate it is the cause or just association in a TMA with transplanted patient?
Right. So, of course, we use different parameters in is histopathologic evaluation. The most useful finding is actually the presence of C4D in the peritular capillaries. We use immunofluorescence staining at the Mayo Clinic. Other centers use immunohistochemical staining. But we also correlate with the presence of or absence of donor-specific antibodies, understanding and recognizing that not all of the patients can, be categorized just on the basis of that information. But if we have a positive donor-specific antibodies and C4D staining, and thank you for asking the question, we certainly favor that it's an antibody-mediated related process. But it's definitely an area that we recognize there are some patients that are not going to meet that criteria and that, may still require further workup to determine what the cause is.
You told us about the positive signs of TMA in the pathology. Did you have any negative sign excluding TMA if it is present in the section or no?
Sorry, I don't think I understood the question. Can you repeat it again?
You have the criteria for TMA in the sections, the thrombotic and others. Do you have any negative signs if you didn't see in the section, this is an exclusion of TMA?
No, that's, thank you for asking that. So TMA can be quite focal, right? And so the absence of these lesions cannot completely exclude the presence of TMA, obviously. So if, there is a systemic symptomatology of TMA, negative biopsy cannot completely exclude that.
Thank you very much for
problem.
interesting.
I have one question regarding the artificial intelligence, please. There is a train program which has been launched in March 2024 in the United States, which is responsible for making a sort of collaboration between the different medical centers, healthcare leaders, trustworthy and responsible AI network. Could you elaborate a little bit about that?
Of course. So I didn't get to go over constraints or barriers of the progress because I want to kind of focus on what could happen. There are significant number of things that we need to overcome. One is that data transferability. So I cannot share data directly unless it is de-identified with other universities that I collaborate. It requires some legal contracts beforehand, and that takes time and a lot of efforts. Now, our institution, we are moving to the cloud-based data. So data is in cloud, automatically de-identified, and other universities, other scientists, other companies, they can buy registration to be able to kind of access our data set. And I think that this is a trend that is going to happen, availability of data between all of it. Second is that infrastructure is pretty limited. We don't have many IT specialists, data scientists that can help us to do that. I know AI, I can develop my kind of simple AI models, but the more advanced models, I really need a data scientist that spent 6 years on to learn that. And this is unfortunately very scarce infrastructure as well. Then the users are the major problem, because even if you provide very good model with very good intervention to clinicians, clinicians are not very good in following those, right? We are terrible in following protocols or recommendations from others. We always see the computers. And that is the example of it provided for critical care pharmacists on vancomycin dosing. They always say that we love these models, but they never follow the recommendation from the model. And that is very concerning. And that requires a lot of work on its own. So yes, there are some efforts in order to enhance collaboration. But 2023, there was a Bill of Rights issued by White House in order to manage AI, in order to make sure that patients are not damaged as a result of AI. AI can potentially be damageful to some cohort of patients, because our patient population are mostly white Americans, and that may not apply to African Americans that we have in our institution, may not apply to other cohorts. And those are all problems that we need to be very conscious of and we manage. One example that is very famous is that there was a model that predicted some radiographic problem. So they gave it to all radiologists. Those radiologists that they were performing poorly, they actually performed better. But radiologists that performed really good, they performed worse as a result of that, because they trusted the machine more than they trusted themselves, and they made more mistake as a result. So we have to kind of be very conscious, monitor that. We have to mitigate at the beginning, but there are some problems that may arise and we don't know. We have to monitor and manage.
Please, doctor, can you see that this AI can replace the doctor relationship with patients? Can you remove the doctors, or what happened?
So this is great question. Yeah, I think that the AI would potentially provide more time between us and our patients, right? So writing notes takes a lot of time, for example. AI can now help us to write notes, just having conversation with patients. Majority of us, when patients, you ask questions from patients, write a note on a paper or type on a computer. This will be going away. Instead, you can actually look at the patient and have a conversation with them. AI takes care of your note. That can potentially open some opportunity for make more more connection with the patients. I think that AI would not replace us. Again, AI intelligence is very narrow. We are kind of the higher authority from the artificial intelligence standpoint. However, clinicians who don't learn how to use AI will be replaced by clinicians who know how to use it, right? If we don't know AI, we are not going to kind of be able to take advantage of that. Eventually, over the course of next 20, 30 years, they will be replaced by those who know how to use it. Just using it, not developing it. So we have to learn how to use it. This is a flood is coming. You can stay and be drowned with it, or you can go over the wave and enjoy it.
Thank you very
Thank you
much.
very
Thank you
much.
very much. We're very, we have to conclude this session, and would like to thank the speakers very much, because if we continue, I'm sure everybody wants to ask more questions, but we have to conclude the session. Thank you very much.
Thank you very much.
بس انا ببعت ممكن بس انا مش بتابع كده خالص. انا فاكر الناس بيروحوا ويجوا. اعرف يعني يعني على الاقل الناس بتوعنا انا عارف هشوف انا، بس مش عارف انا مش لسه هبص في السيشن. لسه هبص في السيشن يعني من كلينيكال نفرولوجي دي خلاص. سيشن 2 ديبيتس. طبعا.
انا عارفه احمد حسن ودكتور
دكتور احمد حلاوه. لا طب لسه مين خلاص. بص عندنا بسم الله الرحمن الرحيم. دكتور محمد طيب مش
طيب ديبيتس
هو طبعا الدكتور جمال السعيد حاجه تعرفها كويس. دكتور صفاء عز الدين من العراق.
تعرف عنه ايه بقى؟
رئيس الجمعيه العراقيه. اي حاجه.
طب قدمه انت بقى.
ما انا مش عارف بس هساله. طيب هنتعامل يعني.
صفا عز الدين. صفا عز الدين. وفي معايا
طيب
هتتصرف في اتنين، كل واحد مننا اتنين.
هتصرف والله. بص حضرتك، دكتور جمال سعدي حاجه عارفها طبعا.
خلاص انت هتقدم
صفاء
مين؟
المختار،
انت
صفاء
هتقدم
عز
مين؟
الدين المختار في
هتقدم مين
العراق.
انت يا احمد؟
نعم.
هتقدم مين؟
ممكن صفاء المختار، بس
خلاص يبقى انت اول جروب.
زي ما حضرتك عايزه وخلاص. ممكن محمد صلاح حضرتك معروف
انا
يعني،
عارفاه.
احمد حسن معروف، خالد
عندي
ابو سيف معروف،
عندي بتاع تونس اهو بس.
دكتور محمد منجي باشا. هي ادوكي اديوكيشن للقصه، هم ادونا.
اديتني بتاع تونس.
طيب في مين تاني يا مصطفى؟
هو
اهو طيب
محمد.
هولر لا انا مش فارقه معايا خلاص كده. هولر ماشي. هو
احمد انت هتقدم انهي؟
زي ما حضرتك عايزه، زي ما حضرتك عايزه، زي ما حضرتك عايزه، اللي انتوا عايزينه.
نقي اتنين، نقي اول.
هقدم حضرتك قدمي احمد حسن عشان هو خلاص.
عشان يبقى اخر اتنين.
ودكتور هاله تقدم خالد ابو سيف طبعا.
لا
بلاش.
هو كل واحد يقدم اتنين بتوعه.
طيب طيب ابتدي حضرتك بجروب 1 وانا هبتدي بجروب 2 ودكتوره هاله تقول جروب 3. خلاص كده. محمد منجي باشا اهو، ومحمد صلاح. انا محمد صلاح هبعت لك. انا
صفاء عز الدين. صفا.
هو احنا هنقدم جروب طب يعني انا هبتدي
انت بتبتدي بالاولانيه.
دكتور جمال سعدي ودكتور
أيوة.
صفا. هو بص ايه تمام. انا
كل 25 minutes السيشن يعني.
دكتور احمد حلاوه انت هتبتدي صح؟
انا هبتدي لان انا ضمن سلايد
بسم الله الرحمن الرحيم. احنا بنتشرف ان احنا بنبتدي ال second session today, the debates in kidney transplantation, which will be moderated in the name of God by Professor أحمد حلاوة. طبعا Professor أحمد حلاوة احنا مش محتاجين نعرفه، يعني هو Egyptian surgeon and scientist في Sheffield Institute in England since a long time. وليه contributions كتيرة جدا في ال assistance of Egyptian society in many aspects scientific. برضو في ال cadaveric program development اللي مصر بتحاول تعمله. النهارده هي moderated debates in kidney transplantation الدكتور أحمد حلاوة، فيبدأ يتفضل إن شاء الله. اتفضل دكتور أحمد.
شكرا. شكرا أخي الفاضل الدكتور أحمد السيسي. Thank you very much for this nice introduction. And I'm pleased to be with you today. It's today actually about clinical transplantation debates. The rule of this debate is the debate is entirely between the two presenters. So we need to see how strong the argument is to defend their opinion. Of course, I will.
First, I'm very proud to be my first time in the Egyptian Society, and thanks for the Egyptian Society to invite me, and for Professor Ahmed Halawa. And I'm very proud to be to have a discussion with the Professor Ahmed Halawa regarding this case. My talk has no objectives and no conclusions. I will concentrate on my slides. That's what the patient is presenting with, and to aid my slides with the discussion with you. I think that the problem is that before 2022, there was no consensus regarding how to define desensitization and how to treat them and how to group them. But interestingly, the ESAT group, the European Society of Organ Transplantation, found the ENGAGE wave in 2022, when a group of experts, about 53 nephrologists, transplant immunologists, and transplant surgeons came into entity that's called the ENGAGE wave 1 and ENGAGE wave 2. And this this slide will show us that the European consensus on the management of sensitized kidney transplant patients at Delphi study. What's the meaning of Delphi study? Delphi, as I mentioned, that they are 53 group of experts in transplantation, physicians, immunologists, and surgeons, and they stand together and they put the different groups of sensitized patients. And when an opinion appears, for example, whether to sensitize this group or not, they will take the percent of the acceptability of these 53 experts, and they will grade the evidence whether to do an action or not. If you, it's very nicely represented here. That category 1, 0 DSA with a positive CDC. There is some interesting back to the basics in this classification, that the CDC and the flow cross-match was done together in all patients who are sensitized. So if we have a patient with 0 DSA with a positive CDC cross-match, the opinion was with not to transplant or to find a suitable, compatible living donor, or go to the paired kidney program. Category 2 was 0, in day 0, a positive DSA with a positive flow cytometry, T and or B, and a negative CDC. This is also classified as being a high risk category, which needs desensitization before transplantation, or going to the priority scale, which is used by some centers, or the use of the European acceptable mismatch program. Category 3, which I think that our patients belongs to, a patient with a positive DSA with a negative flow cytometry. Although the B cross-match by the flow was positive historically and recently in 2024, as mentioned by Professor Ahmed Halawa, we think that that the positive flow by B, and it's repeated in the test, that the auto flow was negative, meaning that probably is a case of SLE with a high titer of IgM antibodies that's mentioned by our colleagues also, and we regard this patient as being flow negative but DSA. Category 4, it's very interesting that the absence of, there is a DSA, but potential cellular memory. What's the meaning of cellular humoral memory in sensitized patients? Here in this Engage Wave 2 program, they defined an interesting new entity, sensitized DSA negative. What is the sensitized patients with DSA negativity? There is in the germinal center, spleen, and secondary lymphoid organs, there is a memory B cells and T follicular helper cells, which are ready to respond to donor HLA. So you don't have a DSA, but you have a potential two important memory cells, B and T, in your germinal centers, that they are ready to cause an accelerated rejection, although it's not a hyperacute one. So this category by the European Society of Organ Transplantation means that even the history of pregnancy or a second kidney transplant or multiple blood transfusions, and you don't know the HLA of the donors of the blood, they categorize them as being a high risk for antibody-mediated rejection, although the DSA was negative. The problem is that there is no yet valid test to diagnose cellular memory. That's to say, the resident memory T and B cells. And the last category will be the patient has no DSA and no cellular memory. There is no history of blood transfusion, pregnancy, or etc., which requires no desensitization. And this was interesting that in 2024, the ESOT has been produced, the ENGAGE program. This is a very interesting analysis, included about 7 retrospective studies. Unfortunately, all of the studies included in this, I think our patient belongs to this category, that he has a DSA, low titer with a negative flow cytometry. And in these 7 studies, all of them has been mentioned that the 5-year graft survival and 1 year and 5-year graft survival was not so different between the two groups. I put this study because exactly our patient will fit the group, the meta-analysis mentioned. And I think Professor Halawa was one of the editors. Yes. So again, for the transplantation group, if you see there, if the patient is highly sensitized candidate, we should assess the degree of sensitization, calculated PRA, consider blood group and sensitizing events, and consider patient preferences. So if this is the answer to this question is yes, are there unacceptable HLA mismatches? If no, consider direct transplant with enhanced immunosuppression. If yes, offer a kidney exchange program or other possibilities apart from probably a priority scale. If you put those sensitized patients in a priority, not on the last on the list, you should put them earlier. They will have a chance of having a better kidney exchange program. Our patient have an HLA-DQ5 with a low titer of median fluorescent intensity. In the early years, DQ was not included in the anti-HLA screening for donor and recipients because there was a high grade of sharing between the DR and the DQ. And for that reason, when you label a patient as anti-HLA DR positive, you are saying at the same time that he is anti-HLA DQ positive at the same time. But recently, many reports has been documented that the chronic antibody-mediated rejection was associated with anti-HLA DQ antibodies, or what's called de novo donor-specific antibodies. So the positivity for HLA DQ region can sometimes harbor a potential risk of an increased chronic antibody-mediated rejection. And this slide will show us that probably if you go for DR7, it is in the first row, DR7, which is associated with 2 HLA-DQ regions. For that reason, sometimes antibodies to HLA-DR7 are associated with 2 anti-HLA-DQ molecules. And for that reason, the anti-HLA-DQ is not always pathologic, but sometimes may trigger if the patient developed de novo anti-HLA-DQ antibodies. And this one, what's interesting, I will talk for 2 minutes about how to diagnose the cellular humoral immunity when the patient is DSA negative. And of course, as I told you, that there is a new entity of DSA negative sensitized patients. That's the idea here, that when the HLA of the donor is internalized by the B lymphocyte and presented, yes, sir, and presented to the
1 minute, please.
1 minute, yes.
1 minute. 1 minute, please.
These are the new tests that is done, that if you have a DSA negative and still you are thinking of sensitivity, you collect the B lymphocytes of the recipient and you let more and more proliferation. And if you take the supernatant of this and repeat the SAB, the single assessment of beads by the SAB technique, then you will diagnose that the patient is having a circulating memory or TB lymphocytes. And this is the best way to categorize our patients. For at the end, as I mentioned, that our patient that's in discussion, I think that he don't need desensitization according to the categories that I have discussed. He's category 3, but the risk-benefit ratio should be discussed with the patient. And in my opinion, I should go for direct kidney transplantation with augmented immunosuppression. Thank you, sir.
Thank you, Professor Safra. So now, shall we vote?
Can we go back to the last slide?
No, no,
That
I mean,
this
we'll vote
particular
now, and then
patient,
I will ask you for your opinion. So, fine. So what do you think, Dr. Ahmed?
Totally agree with Dr. Safa. Totally agree with Dr. Safa. We have 3 unification of opinions is like an absurd in medicine. You can't unify opinions in medicine. You have different algorithms and approach for each patient. For this patient with a very difficult probability to have a donor, this risk attained is a very low risk. he will never have another donor. You stratify patients on 3 categories. Those with the best graft survival with no DSA or no PRA at all, and those with non-DSA PRA, and those with DSA against the donor. The problem here is not the success of the operation, the problem is the survival of the graft. Since this is a previous transplant with a good option for a transplant with a hard probability to get a donor, counseling of the patient for the graft survival will be more than enough to go through this operation definitely. It's his only chance. The second thing that he needs only augmented immunosuppression. He don't need anything. The DSA is 1300, which is minimal. It might be an autoantibodies, and you have a negative cross match. So I don't think that this is negative.
Mr. Dawlat, can we vote, please? I mean, can we get the QR code? And if you don't mind, can you vote whether desensitized or not? Yeah, use your iPhone, please, or whatever phone you have.
Yes,
Your landline.
if we go back to the case to start with, this patient has a very bad chance to find a donor because of his high CPRA. He's a second transplant, he has memory cells, right? If you go back, he has a positive B cell cross-match with a negative auto cross-match. So these probably are not due to the lupus. His MFI is not
Not due to the lupus or due to the lupus.
they are auto cross match is negative in this patient,
Yeah.
according to the provided picture. He has an MFI of 1600, Samsung 1600. We did not know which MFI, which is it DQ or DP. If it's DQ, Ahmed is correct. We have to take it into consideration. If it's DP, we can relax about it, about this class 2, because his T cell is negative, his B cell is positive. It's probably class 2. These MFI, although not mention the type, they are class 2. The cutoff value here is not very high. So should we interfere or not interfere? This cutoff value, probably they don't interfere. But this is a very high risk patient. I think he has to be desensitized and proceed with the transplant.
Desensitized and proceed.
Desensitized.
Fine. Dr. Hala? QR code is not working? نعم؟ طب يا شباب يا لورا هتفضحونا قصاد الأجانب كده.
دكتور احمد، دكتوره هالي هتقول رايها. دكتوره هاله بس.
اكشولي يعني انا لما قريت الكيس انا كنت مع رايي، وسعيده جدا ان الدكتور جمال ان انا رايي زي رايه ان انا الكيس دي ما فيش داعي تو ترانسبلانت ديس دونر. بس انا دخلت في كونفليكت تاني، الهاي ماتشابيلتي سكور بتاعه اللي هو ريليتد للاتش ال اي وللبلاد جروب. فانا بقيت ان كونفليكت، فده هسيبه للكلينيشن تو ديسايد ان هو يعني تو ترانسبلانت اور نوت. وبرضك ديسنسيتايز اور نوت هسيبها للكلينيشن برضك لاسباب كتيره، واهم سبب زي ما الدكتور جمال برضك قال في التوك بتاعته ان الام اف اي انا ممكن لو عملت استخدمت كيت ثانيه ممكن الام اف اي تطلع وممكن تنزل. واكشولي احنا هنا في مصر ما عندناش غير كيت واحده، هو في 2 كيتس، في 2 كومبانيز بيعملوا برودكشن اللي نشتغل بيهم اللي بنكس على الدونر سبيسيفيك انتي بوديز، في 2 كومبانيز. احنا في مصر معظم المعامل بتشتغل بكومباني واحده عشان الكومباني الثانيه مش افيلبل قوي. فطبعا الام اف اي وبرضك زي ما حضراتكم عارفين هو سيمي كوانتيتيف، فبرضك انا I should not take my decision عليه هو لوحده. اوكي، فانا مع يعني لو هفكر هريح يعني هبقى مع immune suppression، بس تبقى جامده ويبقى حريصه ان انا اعمل بي سيل ديبليشن، مش اكتفي بس ان الاندكشن يعمل لي تي سيل ديبليشن، يعني انقي دواء يعمل لي تي سيل وبي سيل ديبليشن الاثنين مع بعض.
اوكي، يعني زي الومتزيماب مثلا.
دكتور صفاء. دكتور, do you believe as an expert in HLA matching that some HLA are overrepresented in the Luminex plate? There was a very interesting entity that some HLA molecules are overrepresented.
طب.
HLA-DQ5 is one of them.
Of course ال
So
GQ
for
وال
that
GP
reason- for
ال
that
GQ
reason,
وال
we will
GP
not take it, we will not take it seriously. But HLA-DQ5 is overrepresented in the Luminex plate, and HLA-C and HLA-DPB1
yes
also overrepresented. So
مش
for that
DQ
reason-
specifically مش DQ5 specifically ال DQ
Not-
generally
yes.
وال DP وال DC وال C sorry
For
دول ال
that
3
reason- For that reason, even if the patient was another case of lupus, I will expect that the HLA-DQ will be overrepresented. Either as you said, change the supplier,
yes
or
it might increase it might
Yes.
decrease nobody can
probably
tell
if you change the supplier and the way to do the flow cytometry or the SAP by another supplier, you will find that probably the MFI HLDQ will be underrepresented and you will go direct. But as I mentioned that this patient also should be screened for ABMR accurately. Every 3 months, DSA should be done and probable a biopsy, a follow-up protocol biopsy.
بس برضك I want to lay stress ان احنا لما بنشتغل الدونر سبيسيفيك انتي بوديز وبلاقي دونر سبيسيفيك اندر الكات اوف انا بريكورد وبقول للكلينيشن تيك كير انا شايفه دونر سبيسيفيك انتي بوديز اقل من الكات اوف يعني انا الكات اوف بتاعي 1000 انا لو لقيت دونر سبيسيفيك اقل مثلا 700 او 800 انا بعمل ريبورت انا الكات اوف بتاعي كذا بس تيك كير ان في دونر سبيسيفيك عند اللو ليفل دوت. انا بس كان نفسي اعرف دكتور احمد احنا عارفين ايه السنسيتايزنج ايفنت يعني هل الدي كيو 5 دي من البريفيوس ترانسبلانتيشن ولا we have no idea
It's not a repeat mismatch.
not a repeat
تمام.
mismatch اوكي
احنا هنستأذن حضراتكم احنا كده debate is concluded according to the voting. لو في اي حد من الاودينس عنده اي كومنت اي حد من our experts عندنا many experts in the audience انا شايف الدكتور صبري والدكتور ايمن دكتور باشا ويعني في ناس كتير قوي experts والدكتور محمد صلاح يعني في ناس كتير قوي experts in transplant. حد عنده عايز يضيف اي حاجه لو ليه اي impact ممكن يفيد بيه في to conclude this point او the first debate.
Shall report from the tissue typing and cross match. So with good success, actually, transplanted 6 months ago, we're working very well. So the second debate is
ممكن دكتور احمد بس اقول حاجه بقى صغيره جدا حضرتك هي
اتفضل.
مشكله البيشنت دوت مش ديسينسيتايز ولا لا لان الانتي بوديز اللي عنده ديسينسيتايز دي حاجه تمبرري هو مشكلته في الميس ماتش العاليه فانا يهمني جدا الاندكشن بتاعه والمينتنس بتاعه يعني دي نقطه اهم منه لو انا قررت اعمل له ترانسبلانتيشن هي دي مشكلته
دكتور
اكتر
هلا هو كده
من
كده العيان ده
desensitization.
هاي ريسك كده كده العيان هياخد اوجمنتد اندكشن هو كده كده العيان هاي ريسك ده this is out of the question فده مش موضوعنا.
ما أنا بقول يعني ده المين
يعني هو ميس ماتشد وعنده هاي probability اوف ريجكشن سكند ترانسبلانت يعني كل حاجه ولوبس عنده كل حاجه فهو اوجمنتد ترانسبلانت.
بص يا دكتور لا مفيش أسوأ من كده. كله بايظ. Okay, next debate, second scenario is a 39 years old lady came forward as altruistic donor, excellent kidney function, editor EGFR and serial urine analysis was absolutely perfect. On this occasion, all other investigations are satisfactory. She had a history of gastric bypass from morbid obesity. Her BMI came down from 40 to 32. So, in conclusion, a very fat lady had gastric bypass, reduced weight. All investigations are satisfactory. She's suitable donor. Donation or not? Will you accept her as a donor or not? Professor Muhammad Salah and Professor Muhammad Mongi Basha. Who's going to start first? Professor Muhammad Mongi is the first time to to visit us in Cairo. He's a professor of medicine.
احنا طبعا بنتشرف بوجود دكتور محمد منجي باشا اخونا من تونس الشقيقه وطبعا الدكتور محمد غني عن التعريف هو prominent Tunisian nephrologist associate professor at the Faculty of Medicine of Tunis. He completed his medical study at the Faculty of Medicine of Tunis and specialized in nephrology, training in both Tunisia and France. Dr. Pasha had significant roles including Vice President of the Tunisian Society of Nephrology, Dialysis and Kidney Transplant, and Chair of the African Association of Nephrology, the Afghan Transplantation Committee. over 70 publications and 227 citations. His research primarily focuses on kidney transplant and chronic kidney disease. اتفضل دكتور محمد وتشرفنا بحضرتك. اتفضل يا فندم.
يعني احنا خدنا نص المحاضرة في تقديم حضرتك، بسم الله ما شاء الله يعني.
So, أهلا وسهلا. Good morning. I would like at first to express my gratitude to Professor Ayman Rifai, the president of the Egyptian Society, and Professor Ahmed Halawa for the kind invitation to participate to this Egyptian Society of Nephrology and Transplantation Congress, and of course to this debate. I thank also Dr. Halawa for the choice of this subject. I would also like to take this opportunity as Vice President of the Tunisian Society of Nephrology and Dialysis and Kidney Transplantation, and as President of the Organizing Committee to invite you to the upcoming Afran Congress, which is scheduled to take place in Tunis from April 15 to 18, 2025. So for more information and to register for the Congress, I invite you to visit our website at afran2025.com. يعني المباراة مش تكون سهلة مع دكتور أحمد صالح بين الأهلي والترجي، ولكن أنا معول على الزملكاوية باش يساعدوني في الفوت. My opinion is that living kidney donation from obese patients after bariatric surgery is a very and beneficial option, and I will justify my position with 6 arguments. I will not repeat the case vignette, and as you know, according to the WHO, obesity is defined as BMI of 30 or higher, and is categorized into 3 classes. The donor's BMI is a key parameter in predicting end-stage renal disease. KDIGO, in their recommendation published in 2017, advocate that the decision to approve donor candidates with obesity and BMI over 30 should be individualized based on demographic and health profiles in relation to the transplant program's acceptable risk threshold, but without specifying the upper threshold beyond which the donation is no longer authorized. The recommendation of the British Transplant Society, published in 2018, state that there is no formal upper limit of BMI for donation, but increased risk with BMI of 30 to 35, and meet a safety data when it is greater than 35. My first argument, Dr. Saleh, is based on ethical recommendation and consideration. In fact, if the donors are well informed and willing, why exclude them? Second, refusing the donation contributes to prolonged suffering for transplant candidates. Of course, the principle of primum non nocere should be respected for both donor and recipient. My second argument is related to organ shortage crisis. While there has been a steady rise in the number of patients with end-stage renal disease, the supply of donor combined living and deceased has fallen far behind the need, resulting in an increased number of qualified patients remaining on the wait list, and thousands being removed from the list every year because of death or becoming too sick for transplantation. Although more than 157,000 organ transplantations were performed worldwide, in 2022, data from the Global Observatory showed that this represents less than 10% of global needs. For kidney transplantation, the number of patients on the waiting list far exceeds the number of transplants performed. Several strategies have been developed and implemented worldwide to expand the pool of both living and deceased donors. However, this effort remains insufficient and may inadvertently encourage organ trafficking. My third argument is about the steady rise in obesity rates among kidney donors. For example, in the US, the proportion of donors with obesity increased from 8% to 26% between the first and the fifth decade of the study. The mean BMI of living kidney donors has increased over time from 24.3 in the 1970s to 27.3 in the 2000. Therefore, excluding potential obese donor will further exacerbate the organ shortage. For our patient, we can consider that she has a low risk despite having undergone bariatric surgery. In fact, she has excellent kidney function confirmed by eGFR and urine tests. Weight loss improved metabolic profile, reducing the risk of hypertension, diabetes, and obesity-related kidney disease, lowering cardiovascular risk compared to pre-surgery status. Concerns about hyperexuria and oxalate nephropathy, these are rare but manageable with proper hydration and dietary adjustment. Long-term studies show stable kidney function in most post-bariatric patients. It seems that sleeve gastrectomy is the most reported and preferable approach since it minimizes hyperexuria risk. A recent systemic review compiled all reported cases of kidney donation following bariatric surgery. 16 out of the 25 reported cases had a post-surgery BMI exceeding 30, with one case reaching 37. Sleeve gastrectomy is the most reported and preferable approach since it minimizes hyperexuria risk. In a retrospective study conducted in Mayo Clinic compared to BMI low than 25 kilo, high BMI donors had slightly longer operative time, more overall perioperative complication, yet the same low rate of major surgical complication and similar length of stay. The results suggest that laparoscopic donor nephrectomy is generally safe in selected obese donor and does not result in a high rate of major perioperative complication. 2 minutes, please. I can pass to the slide, please. The introduction of the Da Vinci surgical system with inherent advantages has expanded the ability to complete solid organ transplantation in a minimally invasive fashion. The initial results showed the viability of this technique in the field. The proven advantage of robotic technique, especially in obese kidney recipients, is a significantly lower rate of surgical site infection. A recent retrospective Turkish study showed low risk in midterm. Killian showed in the study including more than 3,400 patients that living kidney donors with obesity trended toward living longer diabetes-free than non-donor with obesity. My last two arguments are about the recipients. Kidney transplant from obese donor provide an additional opportunity for potential recipients, significantly improving their survival compared to dialysis. Additionally, this procedure offers an extra opportunity for transplantation from a living donor, leading to better survival outcome for both the patient and the graft compared to deceased donor. In a recent study, even cognitive impairments are less frequent after living donor kidney transplantation. In conclusion, dear Professor Mohammed Saleh and ladies and gentlemen, in the context of organ scarcity, declining a suitable donor is an opportunity lost to save a life. Donor candidates with obesity may be considered donors, at least for patients with no other suitable living kidney donor after a thorough perioperative evaluation. Bariatric surgery should not be contraindication. Obese patients should be informed of both acute and long-term risks, especially when other comorbid conditions are present. The donation must be followed by appropriate post-donation follow-up, particularly for metabolic monitoring. Thank you very much.
Thank you, Professor Baga, for you are with donation for this patient. The
Is well,
conclusion, yes.
For donation. So will you introduce Professor Muhammad Salah?
Yes.
Professor Muhammad Salah?
Next speaker, you are against donation probably. Next speaker is Professor Muhammad Salah.
Well done.
Professor Muhammad Salah is the Dean of the National Institute of Urology and Nephrology in Matariyah. He is the Secretary General of the Egyptian Society of Nephrology and Transplantation. He is the Secretary General of the Arab Society of Nephrology and Transplantation. He is the ISN Council and Chair of Africa in the ISN Board. He is the ISN Transplantation Chair, moderator of the Nephrology Division of the National Committee for the Egyptian Guidelines in the Ministry of Health, nephrology representative in the National Committee of the NCDs. Very long.
بس كده مفيش حاجة تانية؟
بنرحب بحضراتكم تاني في ال 43rd Annual Conference of the Egyptian Society of Nephrology and Transplantation in this session. والحقيقة دايما ماتشات الأهلي والترجي بتبقى صعبة وطبعا a very tough competitor. بس الحقيقة الميزة في اللي احنا بنعمله هو ان احنا نطلع بحاجة يعني مش مهم مين هيبقى approved. وده الحالة دي بالذات أكبر دليل لأن أنا الوهلة الأولى لما شفتها أنا كنت طبعا حالة زي دي هاخدها وأقول I'm with من غير أي تفكير. ولما دكتور مونجي قال لي أنا عايز آخد الوذ فقلت له أنت ضيفنا فخد الوذ. حاولت بقى بس لما I dig more لقيت إن الحقيقة فعلا we shouldn't يعني take it for granted. فهضطر ألعب دور حسن سبانخ في فيلم الأفوكاتو عشان أقدر أطلع ألوي عنق الحقيقة إلى حد ما. بس هتكتشفوا إن عندي بعض الحق. ده المعهد القومي للكلى والمسالك. أنا افتكرت لما قعدت خدت أول يعني برضه قعدت أفكر في بتاع الإكسبريشن بتاع أيام بقى في ثانوي لما كنا بندرس هنري IV في شكسبير كان عنده حاجة اسمها فات كيدنيد. فالفات كيدنيد ده اللي هو راجل ملزق كده يعني هو كان الشخصية بتاع فالستاف دوت. فهو راجل كده كان لزج. يبدو ان شكسبير was يعني anticipating اللي هيبروف في المستقبل من خلال الساينس. Quick introduction: obesity has emerged as the greatest global health threat in modern times. Its prevalence is increasing جدا from 1980s till now, almost doubling and tripling. And there is disagreement about how validly we can assess for obesity. BMI طبعا is the most not reliable, the most used way. It's measured by ان احنا بن divide الويت in kilograms square على الهايت. ودايما دكتور مونجي قال احنا كلنا عارفين ان من above 30 BMI بيعتبر overweight. وده ليه degrees class 1 من 30 ل 34, 2 من 35 to 39 and 3 اللي هو 40 and above اللي هو morbid obese. في وسائل أخرى زي waist circumference which is more reliable. Abdominal adiposity is again more reliable. والhip circumference all are more reliable but are more difficult to assess. وبالتالي usually we use the BMI. Potential living donors may be excluded from living donation due to obesity, which could encourage medical and surgical strategies to achieve significant weight loss. Although strongly motivated, لكن ما حدش من الناس دي مهما كان الموتيفيشن بتاعه بيقدر يوصل للoptimum weight إلا 13% only of the cases who can reduce their weight below 35 kilogram per square meter. Bariatric surgery is therefore a potential valid weight loss strategy for potential living donors. However, many ethical issues may arise when considering the opportunity for bariatric surgery in living kidney donors. طبعا hyperexaluria after Roux-en-Y gastric bypass increases the risk of kidney injury. Hyperexaluria, urine oxalate more than 45 milligram per day is an adverse effect of Roux-en-Y gastric bypass that can cause kidney injury in the form of oxalate nephropathy or calcium oxalate nephrolithiasis. Types of bariatric surgery عندنا pancreatic diversion with duodenal switch, gastric bypass اللي هي Roux-en-Y وsleeve gastrectomy. هنلاقي ان افضل وقت هو طبعا نعمله before transplantation will preferred as Professor Mongi mentioned is the sleeve gastrectomy. هنا في الستادي دي اللي اتنشرت في مارش 2023 في الترانسبلانتيشن TTS لقوا ان الدونرز should be encouraged to maintain their weight, avoid adverse lipid profile and hyperfiltration. الدونرز post bariatric surgery يعني هم بيعملوا لكن لازم نبقى عينينا معاهم دايما على الليبيد بروفايل والهايبرفiltration. We maintain weight loss and many of them regain weight again later. The incidence of hyperexaluria in Roux-en-Y gastric bypass among non-stone formers is reported to be 42 to 67% at 1 to 3.5 years of follow-up, which is a very high incidence. Oxalate nephropathy proven by kidney biopsy has poor prognosis as prolonged deposition of oxalate crystals in renal tubules causes tubular damage, interstitial fibrosis, and progression to CKD. In a case series of biopsy-proven oxalate nephropathy after a Roux-en-Y gastric bypass, Nas et al. Reported that the diagnosis was made at a median of 12 months after the surgery and 73% progressed to end-stage renal disease in 3 months. These findings highlight the need to recognize hyperexaluria as a complication of Roux-en-Y gastric bypass and promptly institute therapeutic measures aimed at reducing urine oxalate and arresting kidney damage. Fat malabsorption after Roux-en-Y occurs as a result of the dietary fat bypassing the duodenum and jejunum, where usually its degradation by pancreatic enzymes and bile salts takes place. The undigested fatty acids bind to intraluminal calcium in the small intestine, thus leaving large load of unbound oxalate that is subsequently absorbed in the colon, leading to hyperoxaluria. So the propensity of kidney stone formation in kidneys in patients who have undergone bariatric surgery is well documented and presents a unique treatment challenge. And the pathogenesis of kidney stones involves malabsorption of fat, leading to unbound oxalate being absorbed in excess in the gut. Specific 24-hour urine derangements in the bariatric surgery population included hyperexaluria, hyperuricasuria, low urine output, and hypocitaturia. After Roux-en-Y, it is important for patients to maintain high urine output to limit and to ingest inadequate amounts of calcium. And there is a strong link between BMI and the risk of CKD. حاجة تانية مهمة. Obesity affects the progression of stable kidney disease because it increases the risk of the development of diabetic nephropathy, hypertensive nephrosclerosis, and focal and segmental glomerulosclerosis. نتكلم على donor even before the bariatric surgery. She was obese. Don't forget, she was obese for a long time. ممكن 2 minutes. فده another risk. Renal hemodynamic structure and histological alterations are linked to obesity. Adipokines such as leptin, adiponectin, tumor necrosis factor alpha, monocyte chemoattractant protein 1, transforming growth factor beta 1, and angiotensin 2 are produced by active adipose tissue. Obesity can cause several conditions, including insulin resistance, glucose intolerance, dyslipidemia, atherosclerosis, and hypertension. And there's proof that obesity alone can cause CKD to progress. هسكيب خلاص انا بحاول اقول ان العيانه اوبيز فنخلي بالنا ودي كل حاجات الاوبيزيتي. هسكيب ده. surgical concerns في العيانه دي عملت عمليه, she has adhesions, وبالتالي when you go for this for nephrectomy, even with laparoscopic, you may have many problems. So in conclusion, The incidence of hyperoxaluria is very high, up to 67%. Strong link between BMI and risk of CKD originally, and previous operation can lead to the surgical problems during the harvesting of the organ. So that's my argument. If you choose to take the kidney, it's okay, but take care that the patient should be thoroughly investigated, or otherwise you may miss something. والدونر بتاعك بعد شوية هو نفسه يبقى patient. Thank you.
Thank you very much, Professor Muhammad Salah. So can we get the voting? So while we're getting the voting up, so what do you think? Shall we accept this donor as a donor or not?
The question for this donor is that we have to psychologically assess this donor very meticulously before donation, because there is a big chance of recurrence post-bariatric surgery. They recur, obesity recurs, because somehow this sleeve dilates and they can eat. So this is very important.
She maintained her weight over 5 years.
Yes, this is very important, because then she will need her kidney. If she turns into another overweight person, she will need this graft.
Fine. So the answer is donation or not? Of course. Will you get the screen up, please? Yeah, of course.
Can I ask both speakers, thank you very much for your presentations. Is there any role for the MRI assessment of the visceral adipose tissue to consider that the patient is at a risk of metabolic disorders later on or not? It's not important the subcutaneous fat and the body mass index, but the visceral adipose tissue, particularly the pancreatic amount of fat, is crucial as a risk factor. It might indicate that the patient is at a high risk for developing metabolic syndrome or not. Do you have any data about this?
Do you have any data?
هو في الحقيقة يعني عدد الحالات اللي كان فيها أخذ كلية من إنسان أوبيز، يعني الكل في الكل تقريبا 25 حالة من الحالات، يعني الأوبيزيتي الكبيرة اللي أكثر من 35 BMI. بالنسبة للام ار اي ما فماش حاجة شفت اللي يعني تحكي عليها في الببليكيشنز، ولكن في يعني اكسبلوريشن واحده اخرى اللي هي اللي وريتها في الكلينيكال فينيت، اللي هي توري يعني الاديبوزيتي عند الدونر قبل وبعد العمليه.
هو بس just a small comment، هي ست عندها metabolic syndrome من غير ما نعمل ام ار اي ولا حاجه، ست عندها truncal obesity واكتر من 88 سم اكيد، خلاص دي بي ام اي 40، فخلاص هي كده دن. احنا مش محتاجين نوصل انها عندها metabolic syndrome ولا لا، هي عندها metabolic syndrome. The question is this lady suffered metabolic syndrome and morbid obesity and now she is within the range to donate. Is it ethical and medically sound to donate or not؟ في two debates. debate ان هي ممكن على long run يحصل لها chronic kidney disease according للدكتور محمد قاله، والدكتورة دولة شايفاه ان في very high risk of recurrence. الموضوع تاني في حاجة تانية ان دي not a related donor، it's an altruistic donor. الحاجة التالتة العينة دي المفروض انها جاية من انجلترا، فدي هتبقى under follow up for life as a donor. فهو دول الثلاثة parameters اللي المفروض ان احنا نفكر فيهم when we should vote whether to donate or not. For me, for these three parameters, this is to donate.
Fine. So the story is quite exciting. This story is quite exciting. This patient presented to us 5 years ago and willing to donate. For some reason, we accepted her as a donor. Parameters are the same as, as presented. For some reason, COVID, we found a recipient for her, recipient unfit. 5 years down the line, came back again for donation. We accepted her initially 5 years ago. We thought it should be okay. Let us repeat the investigations. We found that eGFR is down to 60 And with CT angiogram showed that kidney size reduced, both kidneys reduced by 1 centimeter. So what message to me, because I was a surgeon, the first, when it was presented to us 5 years ago, and I was a surgeon when she presented to us 5 years later. So I accepted her as a donor, but I realized later on when we repeated the investigation that there is definite oxalate evidence of oxalate nephropathy. Because how would you explain GFR declined by 30? How do you explain the reduced kidney size? So this is the story.
هي عاملة رون واي ولا عاملة
Rowan
سليف؟
Y.
عشان
Rowan
كده
Y.
مش سليف
So
يعني.
it was a lesson for me just to be careful about these patients. So thank you very much.
معلش يا دكتور احمد، هو زي ما دكتور احمد سيسي يعني، هو السؤال بتاعك هي رو ان واي
Bypass.
وده اللي مدي ال very high risk of hyperoxaluria.
Of course.
If she was sleeve, maybe the risk would be much better.
The incidence of oxalosis after sleeve restrictive operations is much less compared to bypass. Bypass is the worst one.
Yes.
Fine. Thank you very much. So basically, we have to be careful about these donors. Next, 64 years old. Thank you very much, Speaker. 64 years old renal transplant recipient presented to you in the clinic with severe generalized bony pain, not responding to regular analgesia. Her kidney function is stable, creatinine 119 micromole per liter. She is on steroid-free immunosuppression. Her vitamin D level within normal. PTH 2000. Her total calcium is 9.4. Normal level up to 10.2. She was not known to be hypercalcemic before renal transplantation, no iatrogenic or drug-induced hypercalcemia. So the question is, will you treat her medically with senacalcet and calcium mimetics, or you send her to the surgeons for parathyroidectomy? So the debate now between Professor Ahmed Hassan and Professor Khalid Abu Saif.
دكتور أحمد حسن هيبتدي ولا دكتور خالد يا؟ دكتور خالد ولا دكتور أحمد؟ طيب. دكتور خالد النهارده طبعا دكتور خالد ابو سيف استاذ امراض بطن وكلى بجامعه عين شمس سينيور بروفيسور ومن السينيور نفرولوجيست in Egypt will present his case about whether to refer the patient to the parathyroidectomy or to induce medical treatment, different medical treatment.
بسم الله الرحمن الرحيم. شكرا على التقدمة الجميلة دي، وبشكر الأخ الأستاذ الدكتور أيمن رفاعي واللجنة المنظمة للمؤتمر على دعوتي للحضور والوقوف ما بينكم دلوقتي، وأتمنى لهم مؤتمر مثمر وناجح، وبشكرهم على أنهم جمعوني مع الأستاذ الدكتور أحمد حسن. بداية طبعا الحالة دي أنا الجو ستريت فورد نعمل باراثايرويدكتومي، وهنشوف في السلايدز اللي جاية المبررات. احنا عارفين طبعا في الايرلي ستيج بتاع كرونيك كيدني ديزيز الجي اف ار بيبدا يقل، يحصل ديكريز رينال اكسكريشن للفوسفيت وديمينيجد برودكشن اوف كالسترايول فيتامين دي 3. ده بيعمل هايبوكالسيميا، بوث هايبرفوسفاتيميا وهايبوكالسيميا، تعمل لنا سكندري هايبر باراثايرويدزم بالمشاكل بتاعتها من ميتابوليك بون ديزيز، سوفت تيشو كالسيفيكيشن اند اذر ميتابوليك بروبلمز. برضو this will be reflected على الكارديوفاسكولار ستيتس بتاعت العيانين وتزيد الموربيديتي والمورتاليتي. فأي مانوفر أو أي دراج ما doesn't affect الكارديوفاسكولار outcome هيبقى questionable في الإفكت بتاعه. فهنشوف احنا دلوقتي الباراثايرويدكتومي هي اللي هتأفكت ولا السيناكالسيت هو اللي هيجيب إفكت. العيان في الستيجز دي الكي ديجو جايد لاينز قالت نعمل ايه؟ ان احنا وي شود اسيس البيشنت، سوري، ونعمل المانوفرز الستاندرد تريتمنت لو لقينا في ميتابوليك ابنورماليتيز، ان احنا لو بروتين دايت، فيتامين دي ديريفيتيفز وفوسفيت بايندرز. طيب العين استجاب بولي جود، العين didn't respond، في قدامنا one of two lines، either نكمل conservative management medically وندي العيان سيناكالسيت، او ان احنا to go ahead ناحيه الباراثايرويدكتومي. والحقيقه قلنا العيان ده مباشره نعمل باراثايرويدكتومي. البيبر دي اللي بتاعت الايفولف ستادي اتنشرت 2012 وكانت بيبر قويه جدا، كانت مالتي سنتر ستادي وراندمايزد كنترول ودبل بلايند بلاسيبو ستادي، شملت عيانين رقم كبير قوي 3883 مريض، استمرت 64 شهر. فكان الكونكلوجن بتاعها لازم يبقى واضح قوي. كانت بتدرس الافكت بتاع السينيكالسيت على الكارديوفاسكولار اوتكم، وقالت بوضوح سيناكالسيت didn't significantly reduce the risk of death or major cardiovascular events. على العكس كان في عندنا مشاكل منه هايبوكالسيميا وجي اي تي adverse events. ده كلام ده 2012. تتالت بقى البيبرز بعديها بتؤكد هذه المعلومه. في 2013 برضو استادي شافت السيناكالسيت برضو وتاثيره على الاوتكم، قالت هو قلل النيد فور باراثايرويدكتومي، وده مش الهدف عندنا، لكن it does not appear to improve all cause or cardiovascular mortality. 2016 نفس النتيجة، سيناكالسيت قلل الريت بتاع الباراثايرويدكتومي لكن no influence on mortality. في 2018 المعلومة دي تأكدت تاني، قالت الهايبر باراثايرويدكتومي is associated with 15 to 57% greater survival في العيانين بتوع الدايلس اللي عملوا باراثايرويدكتومي. مش كده وبس، it improved الهايبركالسيميا، الهايبرفوسفاتيميا، التيشو كالسيفيكيشن، البون مينرال دينستي، كذلك الهيلث ريليتد كواليتي اوف لايف. في المقابل اللي خدوا الكالسيوم ايماتكس كان عندهم كالسيوم ديرينجمنت، مشاكل في الكالسيوم ليفل، بيشنت ادهرنس كان سيء، ومن الحاجات اللي ساعدت على كده السايد افكتس بتاعت الدراج، بيعمل نوزيا واحيانا فوميتنج، والكوست بتاعه عالي، فده ليميتد اليوز بتاع الكالسيوم ايماتكس. استمر البيبرز بتتنشر تاكد المعلومه دي. 2019 قالوا ان الباراثايرويدكتومي should be considered before سيناكالسيت treatment to prevent new cardiovascular events، وده الهدف بتاعنا من الاول زي ما قلنا، وان لازم تتعمل ايرلي عشان نتفادى الايرلي بوست اوبرتيف كومبليكيشنز ومن المورتاليتي نقللها كتير. 2018 نفس المعلومه، الباراثايرويدكتومي compared مع السيناكالسيت is associated with a lower risk of mortality. even حتى مش في الهيمودايليس بيشنت، في البريتونيال دايليس بيشنتس قالوا ان التوتال باراثايرويدكتومي زود البون مينرال دينستي بتاعت اللامبر سباين والفيمورال نيك، وقلل الاوستيوبروزيس والاوستيوبينيا اكتر من السيناكالسيت. نشوف الكوست افكتفنس بتاعها. الاستادز من كل حته، امريكا، اوروبا، اليابان، الصين، قالت ان اتس كوست افكتيف ان انا اعمل باراثايرويدكتومي على ان انا ادي العين سيناكالسيت. ودي بيبر منشوره الشهر اللي فات واكدت نفس المعلومه ان الباراثايرويدكتومي از كوست افكتيف. نيجي نشوف الجايد لاينز قالت ايه. النايس جايد لاين اللي اتنشرت في 2007 ريفيوت في 2013 قالت كلام واضح جدا، سيناكالسيت is not recommended for the routine treatment of secondary hyperparathyroidism في الدايلس patients. طب امتى بقى ممكن نستعمله؟ قالوا سيناكالسيت is recommended for the treatment of refractory secondary hyperparathyroidism in patients with end-stage renal disease in those, only in those، مش كل العيانين اللي هم who have very uncontrolled plasma level of intact parathyroid hormone، وعرفوه بان 800 بيكوجرام واحنا طالعين. مش بس كده، that are refractory to standard therapy and a normal or high adjusted serum calcium. مش كده بس وبس، اللي هم السيرجيكال باراثايرويدكتومي is contraindicated، ان العيان الريسك بتاع الجراحه اعلى من البنفيت بتاعها فخلاص مش هيعمل. وان احنا الثلاثه بقى ان هم لازم نفولو العيان اللي خدوا سيناكالسيت، وفي خلال 4 شهور لو ما حصلش ريسبونس 30% ريدكشن او اكتر نوقف الميديكيشن. 12 الثاني عيد نشرها في 23 نفس الكلام ما اتغيرش. نيجي بقى على الحاله بتاعتنا اللي هي التيرشري هايبر باراثايرويديزم، دول اللي هم بيبقى عندهم بيرزيستنت هايبر باراثايرويديزم بوست ترانسبلانت وبيبقى عندهم يا هاي سيرم كالسيوم يا نورمال سيرم كالسيوم. التريتمنت بتاعها سيرجيكال قولا واحدا، وهنشوف البيبرز اللي اتنشرت السيناكالسيت في التريتمنت دي راندومايزد ستادي، وقالت الهايبر كالسيميا والهايبوفوسفاتيميا كانوا افكتفلي كنترول، لكن ما اتعكستش على البون مينرال دينستي، ما فادش العيان اللي هو السيناكالسيت، ما فادش العيان. اجين النظر راندومايز ستادي على السيناكالسيت مقارنه الباراثايرودكتومي، قالوا السب توتال باراثايرودكتومي والسوبيريور تو سيناكالسيت in controlling hypercalcemia in these patients. Again في البيبر دي منشوره في البرازيل 20 العين عنده بيخش في persistent hyperparathyroidism بوست ترانسبلانت على طول اوتوماتيك بيحولوه على سب توتال باراثايرودكتومي. اللي بياخد سيناكالسيت يا اما العين رفض يا اما العين الجراحه ما تنفعوش. بس استمرت برضو القصه ان الباراثايرودكتومي از ماتش بيتر عن السيناكالسيت. برضو شافوا الافكت بتاع الباراثايرودكتومي على البوست رينال اوتكم، وقالوا الباراثايرودكتومي should be considered as a treatment of secondary hyperparathyroidism. خصوصا دقيقتين برضو معلش اسمع، خصوصا في العيان اللي هو كانديديت للرينال ترانسبلانتيشن. هنا برضو قالوا ان هو is a good choice باراثايرودكتومي عن السيناكالسيت في كنترولينج هايبر باراثايروديزم. هنيجي بقى للدراسه بتاعت الاستاذ الدكتور احمد حلاوه اللي لسه منشوره السنه اللي فاتت، وشافوا الافكت بتاع البري ترانسبلانت ويزر سيناكالسيت او باراثايرودكتومي على البوست ترانسبلانت اوتكم. هم كانوا يتهموا الباراثايرودكتومي كود افكت الرينا لوجرافت سرفايفل، لا هم كتير برضه بيبرز كتير نفت القصه دي، منها البيبر هنا بتاعت الاستاذ الدكتور حلاوه ان هي الالوجراف سرفايفل ووز كومبيرابل، والعيانين اللي هم عملوا باراثايرودكتومي كان ليس كومن اللي يحصل لهم تيرشري هايبر باراثايروديزم. دي اخر سلايد ميتا اناليسيز، وقالوا نفس اللي احنا قلناه طول المحاضره. باراثايرودكتومي may offer a survival advantage compared to medical management in patients with secondary hyperparathyroidism. Thank you very much.
Dear doctor, your time is up.
شكرا دكتور خالد. So basically, Professor Khalid is with parathyroidectomy, so we'll refer this patient to me for parathyroidectomy. However, Professor Ahmad Hassan has different view.
السكند ديبيت دكتور احمد حسن اخويا يعني وحبيبي، رئيس اسم الكلى في معهد الكلى. احمد حسن طبعا is an expert in renal transplant، وهيقول his debate against الدكتور خالد ابو سيف. اتفضل دكتور احمد.
شكرا جدا يا دكتور محمد. بنشكر طبعا اللجنه المنظمه دكتور ايمن رفاعي ودكتور احمد على دعوتي، وطبعا بشارك استاذي دكتور خالد ابو سيف النهارده، وبرحب بجميع الضيوف. المشكله اللي قدامنا اللي في الكلير جايد لاينز في الاند ستيج رينال ديسيز بالنسبه للباراثايرودكتومي فيرسس سيناكالسيد واضحه، والكات اوف للباراثايرويد هرمون الديبيتابل كله في البوست ترانسبلانت. هي دي المشكله، ما عندناش كات اوف للبي تي اتش امتى ابدا اتدخل في الباراثايرودكتومي او لا. وفي الراندمايزد كنترول ترايلز او البروسبكتيف ترايلز فيري مينيمال اور ليتل بالنسبه للمواضيع اللي زي دي. هنشوف القصه. I will defend on medical treatment سيناكالسيد for this case. طبعا البريفالنس لازم نعرفه في الهايبرباراتيرشر هايبرباراثايروديزم it is variable up to 80%. المعلومه المهمه complete resolution second hyperparathyroidism ممكن يحصل بوست ترانسبلانت، ممكن يحصل في ال 1 year around 30% and 57% of the patient can be normalized post transplant. الفيجر دي بتبين لنا باللايت جراي اللي هو الهايبر باراثايروديزم بيشنت فري اوف هايبر باراثايروديزم بيشنت، والدارك كولمز اللي هو نورمال كالسيميك هايبر باراثايروديزم. لما نشوف البيرسنت نمبر مع الير اوف ترانسبلانتيشن بيبقى فيه بروجريسيف انكريز للبي تي اتش فروم 2002 في الفيرست يير بوست ترانسبلانت لحد 2015 2015، وده ليه اندبندنت ريسك فاكتور على جرافت لوس اند ايفن ويزاوت هايبركالسيميا. يبقى ده فيري امبورتنت تو بي كونسيدر. يبقى اذا التيرشري هايبر باراثايروديزم في الكدني ترانسبلانت بيشن انكريز الريسك للكارديوفاسكولار ايفنت، للرينال اوستوتروفي، باثولوجيكال فراكشر، جرافت لوس، مورتاليتي. الفيجر دي بتبين لنا comparative study between اللي هو الفري hyperparathyroidism مع normal calcemic hyperparathyroidism as regarding this sincere graft survivor in unmatched patient and score matched patient showing significant graft survivor decreased in normal calcemic hyperparathyroidism. يعني بيأثر على الهايبرباراثيروديزم، بيأثر على الجرافت. طب في جايد لاينز في الموضوع ده؟ there is no clear guidelines on the indication and timing of parathyroidectomy versus pharmacological treatment therapeutic target or primary outcome in renal post-renal transplant. ما فيش جايد لاين صحيحه. الكريجو جايد لاينز 2009 هي وقالت لو في لو بوم نومرال ديسيز بالنسبه للعينين وجي اف ار اكتر من 30 ml per minute زي ريكومند في الرينال ترانسبلانت تو ستارت فيتامين دي او كالسترول او الفا كالسيدول والبيسفوسفونيت، ده الريكومنديشن بتاعهم. طب الاذر جايد لاينز في فاريبل جايد لاينز اللي هو in from 2001 up to now في عندنا الكلينيكال براكتس جايد لاينز والكنديان سوسايتي اوف ترانسبلانتيشن رينال بيست براكتس جايد لاينز والكوديكوي 2020 كلهم دول قالوا اللي احنا ممكن نمشي للباراثيرودكتومي افتر فيلير اوف ميديكال تريتمنت، يعني مفيش كلو واضح اللي انت تبدا باراثيرودكتومي ولا لا، لكن ابدا ميديكال تريتمنت وهنعرف بعد كده ليه. السيفتي، مين السيف بالنسبه للدراجز ولا باراثيرودكتومي؟ السيناكالسيت الموست فريكوينت سايد افكت السيناكالسيت واز جاستريك انتولرانس should be respected طبعا because may have limited dosing and الكومبلاينس للبيشنت ما بقاش كويس. طب بالنسبه للافيكاسي طبعا في دي سيستميك ريفيو ميتا اناليسيس وريسبكتيف وريتروسبكتيف ستادي من 2004 ل 2012 خدت حوالي 21 ستاديز و411 عيان وشافوا الافيكاسي بتاعت السيناكالسيت اللي خدوا البيشنت بوست ترانسبلانت من 3 اشهر لحد 24 مانث. وطبعا زي كونكلود السيناكالسيت appear to be safe and effective for the treatment of post transplant hyperparathyroidism. Another systemic review from Cochrane والبادميد وسكوباس داتا ودول قارنوا ما بين الكالسترول والباراكالسيتول والسيناكالسيت باراثيرودكتومي وكونكلود برضه السيناكالسيت seem to be a good candidate in the treatment of post transplant hyperparathyroidism. دي UK study review article كان فيها دكتور احمد حلاوه برضه وزي concluded the cinacalcet has been showed an improved bone biochemistry and reduced the number of required parathyroidectomies. It remained the treatment of choice for high turnover bone disease in the first year after transplantation, sometimes serving as a bridge to surgery. طب ليه ما ملولش الباراثيرودكتومي؟ طبعا ده انفازيف وبيبقى فيه كومبليكيشن ووند انفكشن تمبروري اور بيرمننت ريكارنت لارنجر نيرف بالسي هاي ريسك الهايبوكالسيميا عشان ترانزيت او بيرمننت عشان الهانجري بون سندروم possible reduction في renal function optimal timing والسويس اوف سيرجري الهيلث سب توتال او توتال دي برضه فيها ديبيتابل. في according to the United States Renal Data System Information on Parathyroidectomy سنة 2007 ل 9 وجدوا المورتاليتي 2%، ري هوسبيتاليزيشن 24%، نيد انتنسيف كير 29%، 39 في الفيرست يير هوسبيتاليزيشن، موست فريكوينت ديسوردر هايبوكالسيميك مايوكاردال انفاركشن اريزميا. دي برضه ستادي سنة 2012 بتقارن ما بين السيناكالسيت والباراثيرودكتومي. طبعا الموست كومن كومبليكيشن مع الباراثيرودكتومي. الاوت كم السمري دي الستاديز ريبورتنج للجرافت فانكشن افتر باراثيرودكتومي هنلاقي اغلبيه الستاديز وكلهم بيقولوا في انيشال ديتيريشن الكدني فانكشن افتر باراثيرودكتومي في رينا ترانسبلانتيشن. ريجاردنج سيناكالسيت زي الميتا اناليسيس ستادي اللي احنا قلناها وجدوا في من ال 21 ستاديز 14 على الاقل نو سيجنيفيكانت تشينج ان سيرم كرياتينين مع السيناكالسيت. الباراثيرودكتومي تايمنج اوف ذا سيرجري برضه فيها ديبيتابل زي ما قلنا. البوست ترانسبلانت باراثيرودكت ليفل appear to be full rapidly in functioning allograft من 3 ل 6 months and after that gradually decrease لحد تبقى بلاتوينج after 1 year. يعني احنا لازم ندي فرصه للبوست ترانسبلانت بالميديكيشن لانه ممكن يحصل الباراثيرويد والكالسيوم بيتحسنوا بعديها مع الجرافت. Enough time should be given to spontaneous regression for gland hyperplasia if surgery is planned post transplant. بالنسبه you must balance between cinacalcet and parathyroidectomy. بالنسبه للهي فانكشن السيناكالسيوم طبعا superior للباراسايرويدكتومي as documented by multiple research. الباراسايرويدكتومي should be performed before kidney transplantation. لو كان سيفير كيس قبل ما ازرع يبقى لازم اشيلها الاول عشان الاوت كام بيبقى افضل. ولو كانت لسه سيفير ممكن بعملها بعد سنه. The treatment should be individualized, and while parasitectomy is recommended for persistent hyperparathyroidism, patient consider at high risk for surgery can alternatively be treated with cinacalcet. So don't forget اللي هو طبعا السيناكالسيت الايفكت بتاعه في الاولد ايج اكتر، واور بيشن 64 سنه، يعني تو ديكريز الباراسايرويدم مور والكالسيوم بيبقى مور افكتيف في 60 ل 64 years. 1 minute more بس 1 minute. في رود ماب جت من اليابان ودي ادت لنا الاونلي سيرجيكال انديكيشن بوست رينال ترانسبلانت لو كان الكالسيوم اكتر من 12 او لو هايبر كالسيميا، لو كوريكتد كالسيوم مور ذان 11 مع سيفير سيمتومز او مور ذان 1 year بوست ترانسبلانت وهايبر باراسايرويدزم وكالسيوم مور ذان 11 كوريكتد 1. So to conclude, cinacalcet seem to be safe and effective treatment for post-transplant parasitidism and maybe alternative surgical parasitectomy. It seem to be effective treatment to identify biochemical abnormalities post-renal transplantation. Randomized controlled trials are larger. Longitudinal observational studies are needed to evaluate long-term efficacy and safety. If parasitectomy is planned post-transplant due to very high BTH and serum calcium, enough time should be given to spontaneous regression for gland. Persistent disease should be delayed at least 3 months, but not extend for more than 1 year to form cumulative risk for cardiac and bone and graft complication, which can be associated with hyperparathyroidism and high calcium. Thank you very much for your attention.
Your time.
Professor Ahmad Hassan thinks that parathyroidectomy is a crap operation who should start medical treatment. Yeah, fine. So shall we vote? It's working. Okay. Oh, شغال اهو. So
we just need to diagnose the case. Is this a case of tertiary hyperpara? Will calcium is just 9? Or is it an adynamic bone disease? You consider this high sky PTH and the 9 calcium? Both of them will need parathyroidectomy.
If you would like to diagnose a dynamic bone disease, we have to have bone biopsy.
Okay.
That's number one.
So
because can't rely. Of course, if you can see alkaline phosphatase 0, means most likely it's alkaline. But calcium is within
9.
Normal,
it's
within
9.
normal range.
Within normal.
Yeah. So
and the PTH is very, very high. So
very high.
So we need an ultrasound, just an ultrasound. It will show the adenoma and then take it off.
Fine. Imaging is not used for diagnosis. Sorry. Okay.
Very important دكتورة دولة قالت عليها ultrasound to rule out لو هايبربليزيا يبقى you will suspect اللي هو resolution أو improvement of BTH of course and even in early nodularity. But if by ultrasound show nodule أو multi يعني the nodule involved all the gland, this means down regulation of the vitamin D receptors, calcium sensing receptors, and even the fibroblast 23 receptors, and so the drug will be not affected at all. And this is parasitectomy should be at that time should be go on.
ممكن دكتور أحمد well actually يعني most of the patients will resolute after renal transplant. We don't have any timeline about the PTH levels. And we presume that this is an intact molecule of the parathyroid gland. The third thing that this is a post-transplant and we didn't have an idea whether this is not a typical tertiary hyperparathyroidism with autonomous gland and it might be a part of multiple endocrine neoplasia. This is a post-transplant case with a 2,000 picogram parathyroid gland. If this gland is a secondary hyperparathyroidism, will never reach this levels. So we have either one of two options. Either this is a tertiary gland, an autonomous gland, and this autonomous gland will not be treated except with surgery, Otherwise, we have another PTH non-intact molecule or related protein, and this case must be thoroughly investigated for other causes of rise in the parathyroid gland. Yeah, it's not that easy. It deserves an isotope study, of course. If the gland is autonomous gland with a tertiary pattern with an adenoma, surgery is mandatory. If it is hyperplasia, it will be something very strange. If not both, search for another thing. Multiple endocrine neoplasia, post-transplant, something else.
All right, thank you, Professor Ahmed, for this comment. You will never know whether it's hyperplasia or adenoma, number one. Number two, you don't need to know because this is tertiary hyperparathyroidism post-transplantation, basically. So the treatment of choice is operation. Yeah, number one. Number two, you don't need to localize it because it's 4-gland exploration. And cystomebi scan, all localizing scans are inaccurate in multi-gland disease. So basically, I will operate. But to be honest, you know, many of my nephrology colleagues will treat with cinecalcet first. And if the treatment fails, will refer patient to me. So voting. Parathyroidectomy, well done, thank you. Fine. Professor Ayman, we finished the session. Thank you very much. You have a question, Professor? Yeah, entirely up to you. You are our guest.